Yes, sir, we are live.
Okay. And you can hear me okay, right?
Yes, sir.
All right, very good. Good morning, everyone. I welcome you all to the updated post-COVID rehab talk. This is going to be a webinar series, which will span over a period of 4 days, not continuously, but you should be able to see the dates on the invitation that has been sent. We have speakers from various disciplines. We have an intensivist and a pulmonologist. We have a rehab medicine doctor. We'll also have speakers from speech-language pathology and physiotherapy. So each of these disciplines will be speaking on post-COVID rehab from their perspective. And as we can understand, the reason we are focusing on this talk is because things keep changing with COVID. New treatments keep coming up. The guidelines continue to change. And the number of cases continue to rise. At the same time, there is a need to reopen the economy. So it is clear that this is something that we are going to live with for quite some time. And as rehab professionals, we want to stay up to date on all the things that are happening new treatments, new guidelines. We want to be up to date in each of those things. So the talk is going to happen for an hour approximately. There is a chat section on the right-hand side corner of the YouTube video. Please post your questions on the chat section, and at the end of the presentation, I will take the questions and present it to the speaker. And if you have any further questions, or if you're not able to view the chat, there is a contact number on the invitation that has been sent, and there is also an email address. Please contact the phone number or the email address, and they should be able to help you out. So with that being said, we have Dr. Navita Ramesh today. She's a pulmonary and critical care physician at UPMC Pinnacle in Harrisburg, Pennsylvania. She's the president-elect of the Pennsylvania chapter of Critical Care Medicine. She's a distinguished chest educator at American College of Chest Physician. She's also a faculty at Chest and American Thoracic Society. She's board certified in internal medicine, pulmonary and critical care medicine. She holds a testimer status in advanced critical care echocardiography. Without further delay, I would like to ask Dr. Navita Ramesh to take over. Thank you.
Thank you, Harish, for having me here today. So my talk today is going to focus on COVID-19, mostly the critical care aspect, and with a lot of focus on rehab. So I have no financial disclosures. To give you an overview of what we will be learning today, I have the first half of my presentation dedicated to what is COVID, how do you manage ICU patients who have COVID, And the second half of my presentation would be the post-COVID manifestations and the post-ICU syndrome. So the overview, we're going to talk about the background, epidemiological data, what is the pathogenesis, disease course, and I want to focus specifically on COVID in the ICU. We will talk about ARDS, or acute respiratory distress syndrome. What are the guidelines for management? And we will briefly touch on cytokine storm, venous thromboembolism, sepsis, and the neurological manifestations associated with COVID-19. And then we'll move on to post-ICU syndrome, or PICS. So the coronavirus, as you know, it belongs to a large family of viruses, and they've caused several illnesses in humans. They initially infect animals, and from there it spreads to humans. So far we've had MERS, which is Middle Eastern Respiratory Syndrome, SARS, or Severe Acute Respiratory Syndrome, and now we have COVID-19. So how do we get infected with this virus? What's the mechanism of action? So the SARS-CoV-2 virus, it binds to the angiotensin-converting enzyme 2 receptor on the target cell. So it gets attached to the receptor and goes into the cell by endocytosis, and then there's replication and viral release, and hence the disease progresses. So this receptor where the virus binds, it's in most of the cells of the body, but it's concentrated in the pulmonary endothelium, the type 2 alveolar epithelial cells, the proximal renal tubules, and the gastrointestinal cells. This could give you an idea as to why these patients mostly have pulmonary manifestations in severe disease, because of the concentration of the receptors. Virus, none of us have had immunity so far. Initially, the outbreak was at Wuhan in the Hubei province in live animal market in China, in Wuhan. A very brief time frame. All this has happened in the last 9 months. So I just wanted to update everyone on the brief, what's been going on in the last 9 months. So in December 2019, Wuhan city, which is the capital of the Hubei province in China, they reported an outbreak of pneumonia of unknown cause. In January, the Chinese scientists, they found this, they isolated the novel coronavirus, and they called it SARS-CoV-2, or Severe Acute Respiratory Syndrome Coronavirus 2. Within a month, WHO designated this disease as COVID-19. And again, within a month, in March, WHO again labeled this COVID-19 as a pandemic, because 114 countries had been seeing cases by that point. So as of today, COVID-19 cases are reported in about 188 countries or regions worldwide. So this is the data I wanted to show you about the spread of the disease, or the extent of the disease. From the Johns Hopkins website, they've been tracking the coronavirus cases from the very beginning at the Coronavirus Resource Center. As you could see here, the countries are listed by the number of cases. The number one is United States, which has about 6 million, slightly over 6 million cases. The second one is India with 4.4 million cases. And on the right side here, you could see the number of deaths, the global death rate. There are about 904,000 deaths so far, and 75,000 of those deaths have been reported in India. So I just wanted to give a minute for this slide, just for everybody to know India is number 2 so far. And as some of you may have attended, I presented a similar talk in May, so 4 months ago, where this was the count. So the total count in the United States was about 1 million, and you could see that India is not on the top 10 list. So at that time, India was at number 15 with 42,000 cases. So within 4 months, it's risen from 42,000 cases to 4 million cases. So as Dr. Sampath Kumar mentioned initially, there's definitely increase in the disease prevalence and incidence. So now I want to briefly talk about what are the risk factors. So it's usually studies so far that have come out within the last 9 months have reported increased incidence in individuals who are older than 55 to 60 years of age, have underlying comorbid conditions such as diabetes, high blood pressure, COPD, chronic lung disease, chronic heart disease, chronic kidney disease, or immunosuppression, that is transplant patients or HIV patients, and also sickle cell patients. And more literature is coming out with just obesity being an independent risk factor for the development of COVID-19. The clinical features, the incubation period is thought to be about 14 days. And usually symptoms develop within a median period of 4 to 5 days from exposure to an active case to symptom onset. Excuse me. So one study reported that about 98% of these patients who are exposed will develop symptoms within 11 and a half days. The clinical presentation is extremely varied. Most common presentation is non-specific flu-like illness. Fever and cough and anosmia or ageusia, which is loss of smell, loss of taste. Those are the most commonly reported initial presenting symptoms of COVID-19. There have been case reports where people have reported muscle aches, headaches, confusion, or even GI symptoms. And we are seeing more and more patients coming in with thrombotic complications, such as patients coming in with strokes, and patients also coming in with pulmonary embolisms and DVTs. And so this area is fluid. The literature is still evolving. And this is important to understand. A majority of these patients who have mild disease, so the mild non-specific flu-like illnesses, they usually don't present to medical attention. And if they don't present to medical attention, they don't get tested and hence not counted in the overall the numbers. And that's a reason why you might hear people saying maybe the disease is, the counts are underestimating the total disease burden. So most patients, over 80%, don't get hospitalized. Among the 20% that get hospitalized, about a third, less than a third of them get admitted to the ICU. And of those, only about 3 to 10% require intubation, and 2 to 5% die. So all this depends upon your total N, or the total number of cases. So if your number of cases increases from 40,000 to 4 million, the number of patients admitted to the ICU and the number of deaths are also going to increase. The important thing with this disease is, especially in the ICU population, these patients have prolonged ventilator dependency. I will be talking a little bit more about this, but it's important to understand that the disease runs its course before they get better and they can be safely extubated. The common presenting, as I mentioned, fever, fatigue, dry cough. And this slide it looks a little busy, but this looked at all the studies from various regions of the world. Just looking at the initial presentation, and as I mentioned earlier, it's just to reiterate that fever, shortness of breath, cough are the most common presenting symptoms. So with that background in mind, I'm going to dive a little bit more in detail into COVID-19 in critically ill patients. This is a whole new world in itself, so I'm going to try to be as comprehensive as possible. So the severity of disease in critically ill patients, 9 to 14% of patients have severe symptoms. Severe symptoms are described as hypoxia or more than 50% lung involvement. And about 5% have critical symptoms where the patients have other multi-organ dysfunction, including shock. This is a study that came out in the beginning of somewhere in the middle, somewhere in the March or April of the pandemic, where they looked at survivors versus non-survivors. So basically this looked at patients with COVID-19, and they divided them into, the studies looked at patients who survived the hospital course and the ones that did not survive the hospital course. Both the survivors and non-survivors presented with cough and fever. And as you could see, by day 9 or day 10, that's where all the complications arise. So in survivors, by day 9, they have sepsis, and by day 10, they have ARDS, or acute respiratory distress syndrome. And the hospital course is prolonged, so that they were admitted, or they were discharged at hospital day 22. median hospital day 22. That's important to note. So non-survivors, so they usually the day of death was on day 19 of hospital admission. And if you see, even in this population, by day 10, they develop sepsis, day 12, they develop ARDS. And the ones who did not survive did have other multi-system organ involvement as well. Just to reiterate that point, so sepsis occurs in a median of 9 days of your illness, ARDS usually within 12 days. And once this sets in, the respiratory status can decompensate very rapidly. And to reiterate the point again, cardiac injury, kidney injury, secondary infection usually occurs between day 15 to 17. So within 2 weeks of the illness is when some patients start having multi-system organ involvement. So I'm going to focus on the top half of the screen. So when we talk about COVID and critically ill, so critical illness is, you look at the whole body. So it's not just an organ system. So when we look at COVID patients, we see all these manifestations. ARDS, or acute respiratory distress syndrome, will touch base on cytokine storm, hypercoagulable states like DVTs and pulmonary embolism, undifferentiated shock and sepsis and related to COVID-19, and strokes. There have been other manifestations also, but I'm not going to be focusing on that. They are less common when compared to the ones on top. So first, what is ARDS? ARDS is acute injury, so it's diffuse. There's bilateral lung injury. There's increased lung weight and loss of aerated lung tissue, given all these, the increased pulmonary vascular permeability, and the patients are hypoxemic too. So the PF ratio, that is the PaO2 to FiO2 ratio, that is how much oxygen is there in the patient's blood, when compared to how much oxygen you're actually giving the patient, it's usually less than 300 in ARDS patients. And all these symptoms, the X-ray findings and the hypoxemia, must not be fully explained by cardiac failure. So the severity of ARDS has been divided into 3 based on the Berlin criteria: mild, moderate, and severe. These are all based on the PaO2 or FiO2 numbers, or the ratio. So the PF ratio is less than 300. So if it's 200 to 300, it's mild ARDS. So in patients who have mild ARDS, the mortality rate is 27%. As the severity increases, the mortality rate increases. So if a patient has severe ARDS that's very hypoxic, if their PaO2 FiO2 ratio is less than 100, they have 45% mortality rate. So that's important to understand. This slide briefly it gives a demonstration of what exactly is ARDS. If you look at this picture here, the one half is a normal lung alveolus. It kind of looks clean. There's not too much going on in there. You have type 2 cells, you have macrophages. But then when you look at the right side, the other half is the injured alveolus during the acute phase, or ARDS. The second half looks kind of busy. There's a lot of inflammation. There's activated neutrophils, a lot of cytokines, sloughing of the bronchial epithelial cells, and there's protein-rich edema fluid. So this fills up the alveoli and hence impairing the oxygenation. So when we talk about COVID-19, it causes ARDS, first by this ARDS, or acute inflammatory mechanism, where it's a hyperinflammatory state and all the tumor necrosis factor and all the interleukins are hyperactive there. And also the virus itself can have a direct cytopathic effect on the alveolar cells. So I keep going back to this because it's important to understand that ARDS in COVID-19 is actually a big deal. And so the mortality rate is pretty high. If you look down here, in critically ill patients, not all patients that come to the ICU are intubated. Studies have shown that up to 60% of patients can receive high flow oxygen therapy. And about half of them, 47 to 71%, depending on which study you look at, they've received mechanical ventilation. And a small proportion, about 3 to 12%, have been supported by ECMO, or extracorporeal membrane oxygenation. I will be talking about that briefly. So what's different with COVID ARDS? So we've been seeing ARDS all this while with aspiration pneumonia, with pancreatitis. We've seen ARDS, but what's different with COVID ARDS? So far, there are two types of ARDS that have been described in relation to COVID-19. So type 1 and type 2. Type 2 is decreased lung compliance, which is basically the ability of the lungs to expand. So the lungs are not able to expand just because of all the inflammatory exudate in them that fill up the alveoli. That's the common type. Type 2 is what we are used to seeing with your lung compliance being less than 40. In ARDS, there is a new mechanism that's described where the lung compliance is normal. The lung compliance is more than 50. So the lung is able to expand. However, the severe hypoxemia seen in this type is mainly due to VQ mismatch or ventilation perfusion mismatch in this population. So with that background with ARDS, a patient comes to us with all the COVID exposure, you have that right time frame, they have these classic symptoms, and you think the patient's in ARDS. So the diagnosis is the current gold standard is RT-PCR, and it's a nasopharyngeal swab. So this is another area which is evolving. So I'm sure we'll see more, we'll see different swabs and different methods of diagnosis coming in the near future. So the nasopharyngeal swab is the primary site for PCR testing. However, if patients cannot tolerate the nasopharyngeal swab, like if they have epistaxis or any recent surgery, then oropharyngeal swabs can be used. But however, you have to understand the sensitivity is lower in oropharyngeal swabs. And if a patient's intubated and you're doing a bronch, the deeper respiratory samples that you get with the bronchoscopy, that shows improved sensitivity over nasopharyngeal swabs, especially in the later course of the disease. So saliva tests are coming out, but we don't have too much clinical evidence to strongly support them. But as I mentioned, this is an area of evolution. So there is no classic diagnostic test for COVID-19. The nasopharyngeal swab would be positive. And then the other supporting evidence, the laboratory abnormalities, it's usually normal procalcitonin. Procalcitonin is an indicator of bacterial infection. So COVID-19 is a virus. There is emerging evidence, again, to talk about superimposed flu, superimposed bacterial or fungal infection. But so far, what we know, if a patient has pure COVID-19 illness, that procalcitonin would be normal. The patients are lymphopenic. So the lymphocyte counts are low. We are used to seeing neutrophil counts, especially in sepsis, and we look at the absolute neutrophil count and you look at the blasts and all that. But for this disease in particular, there's lymphopenia. So there's elevated neutrophil lymphocyte ratio. The C-reactive protein, which is an indicator of inflammation, is high in COVID-19 patients. And it's interesting to note that the D-dimer levels, which usually indicates a hypercoagulable state and it's an acute phase reactant, it increases with time and it's associated with worse outcomes in COVID-19 patients. And the standard respiratory viral panel that we used to use in the lab, which helps differentiate, RSV, flu, human metapneumovirus, parainfluenza. So none of those are going to be positive. And if you start seeing elevated troponin levels, that's an indication that the patient could have underlying viral myocarditis. So radiology. So we've seen patients presenting to us. We saw the presenting features. We saw the diagnostic tests, laboratory workup, and how would their X-ray look, or how would the CT looks for you to increase the suspicion of COVID-19? So far what's described is there's atypical pneumonia or organizing pneumonia, and it's usually bilateral, more peripheral and at basis of the lungs. And bilateral findings has been a classic finding. In about 85% of the cases reported so far, the lung findings are bilateral. And it's interesting to note the evolution of these lung abnormalities, where on day 0 to 5 of illness, It's mostly ground glass opacities, like hazy ground glass opacities, some interlobular lines. As the disease progresses, as you progress from day 6 to day 11, the ground glass opacities become less and they start becoming more irregular. And towards the second week of illness, day 12 to day 17, is when you start seeing more consolidation. And beyond that, you're going to see fibrotic changes in the lungs. So once the fibrosis sets, just like regular non-COVID ARDS, it's going to be very hard to treat these patients. Excuse me. So what we need to do is recognize early and act within the first 2 weeks in order for us to have a better outcome for our patients. And it's important to know what is not suggestive of COVID. So far, we haven't seen much literature on large pleural effusions due to COVID, cavitations, nodules, or lymphadenopathy. So once you start seeing these findings of pleural effusions, cavitations, multiple lung nodules, or mediastinal and hilar adenopathy, it could suggest another process. So I just have 2 images here as examples to see how the disease could progress. The first image is earlier. So you see these ground glass patterns, more peripherally located ground glass opacities. That's usually seen within day 0 to 5 of illness. As your disease progresses, it's diffuse, consolidated, bilateral, as in the second X-ray finding here. It's a consolidation here, there's a consolidation. So this could kind of give us a time frame as to where this patient is in their illness. So the treatment, I'm going to focus on treatment of ARDS, and then I will broaden it to talk about treatment of COVID-19 in general. So in the ICU, when I have a patient with COVID with ARDS, my main goal is to oxygenate the patient and support them to get through this phase of illness. So the target oxygenation is we usually target for 92 to 96%. However, if your patient is baseline oxygen dependent COPD, then we target around 88 to 94%. Our goal is to decrease the respiratory rate below 24 to maintain stable worker breathing, and make sure the patient does not use accessory muscles. That's what we're working towards. Prior to delving into the actual treatment, it's very important to stress on the fact that prevention is better than cure. So wash your hands, keep distance of 6 feet, 1 meter between yourself and others. Don't touch your eyes, nose, or mouth with your hands. Cover your cough, seek medical attention if you have any of those initial symptoms that I had mentioned, and follow the local regulations. So that's important. Prevention is always better than cure. And how can we deliver oxygen to our patients? So nasal cannula can go up to 6 liters a minute, and then this is what we follow. We initially give nasal cannula. Once it hits beyond 6 liters, we switch the patient over to a simple face mask that could go up to 10 liters a minute, despite which if they are hypoxic, then we switch to a non-rebreather mask, which usually goes up to 15 liters a minute. And initially, in the beginning of the pandemic, there was a lot of push on early intubation and mechanical ventilation, just given how quickly these patients can decompensate. Now we have more negative pressure rooms, our PPEs are appropriate, and hence we've been a little bit more relaxed, and we've been attempting at least to use non-invasive ventilation and high flow nasal cannula options prior to intubation in our patients. However, it's important to note that those are aerosolizing procedures, the high flow nasal cannula and non-invasive ventilation. So use your clinical judgment and always use it in a negative pressure room with full personal protective equipment, which includes an eye shield, N95 mask or a PAPR, a gown, gloves, so the full protection before you opt for either of those. And if a patient, despite all this, if my patient needs intubation, then rapid sequence intubation, which is sedation plus paralytic agent or neuromuscular blocker, is usually used, and we do not like to bag valve mask these patients and bag them, because bagging itself is an aerosolizing procedure. So we try to use our most experienced person to intubate the patient, and it's going to be a video laryngoscope in order to increase our first pass success, and there's no bagging again. So now I've intubated my patients with COVID ARDS, and what do I do with sedation and delirium management? So this holds true for any kind of sedation, which is non-COVID related, non-ARDS related. How would you sedate an ICU patient? There is no golden drug. There is no specific drug for sedation and delirium management in ICU patients. The goal is pick a drug that works for the patient, but the most important thing is to lighten your sedation. Don't keep them heavily sedated. You want to lighten the sedation to allow the brain to take over and regulate the body function. So that's key. So during this webinar series, some of our other experts will be talking more about this, but I wanted to mention very briefly about the Society of Critical Care Medicine, ABCDEF bundle. So each of those letters stand for a specific aspect of ICU patient management. So A stands for assessing and managing pain. B is spontaneous breathing and awakening trials. So you want to hold sedation, have the patient breathe on their own. C is choice of sedation. D is delirium. E is early mobility and exercise. And F is family engagement and empowerment. It's important to know that each of these aspects improves patient outcomes in ICU. And when they are all used together, that also improves the patient outcomes. So I think this should be standard of care in all ICUs, if they're not already. So my patients are intubated. We've tried all the other oxygen modalities, eventually intubated, and then we've worked on sedation. And the next part is the ventilator management. So it's ARDS management, which is low tidal volume, 6 to 8 ml per kilogram, predicted body weight, and we want to make sure the target driving pressure is less than or equal to 14. So the target driving pressure is basically your plateau pressure on the ventilator minus the PEEP, so that should be less than 14. And there is standard odds net protocol, PA, the FiO2 and PEEP titration table. So we usually go by this table, and this is available to everyone online. So I just want to go over this flow chart. First, you have a patient who's mechanically ventilated. You have them on 6 ml per kilogram ideal body weight. As per the table, you do the PEEP FiO2 algorithm. You find a good spot for your patient. Then you find out, is this ARDS or is this other than ARDS? You confirm that it's ARDS, but the patient's not improving. That is, your PEEP is over 10 and your FiO2 is over 60% oxygen, and they're still not oxygenating well. At that point, you're going to focus on prone positioning and a trial of paralysis. And then we consider alternative therapies if the patient does not improve. So I will be touching base more on prone position and paralysis, and then from there going to ECMO. So how does that affect the ICU patient during the ICU stay and as well as their post-ICU recovery phase? So once we've sedated our patients, paralyzed them, we do something called prone positioning, where the patient lies on their stomach and not on their back. So we start doing prone positioning if they are very hypoxic. As I had mentioned earlier with the ARDS definition, it depends on the oxygenation status of the patient. So your PaO2 FiO2 ratio is less than 150 after 4 hours. Even if you've given over 60% oxygen to the patient and your PEEP is over 10, then we initiate prone positioning. This is a picture of a patient who's prone positioned. As you could see, the number of drips on the side, and the patient's intubated. So the patient is definitely heavily sedated and paralyzed at this point. The CT demonstration of prone positioning. So the top two diagrams, A and B, the patient is supine. So they're lying on their back, and you can see this, the bottom, that is the dependent part of the lungs, is not well aerated. Okay, it's filled with the inflammatory exudate, as I had mentioned earlier in this ARDS pathophysiology. So it's filled with that inflammatory exudate, and given the gravity and also the body positioning, that part of your lung is not expanding. The second two diagrams here, which is C and D, are prone, where the position is lying, where the patient is lying on their belly. So you see, these are the posterior aspects of the lung, which are shown here. they have expanded much more significantly than if they were supine. So that's the goal of prone positioning. And that's standard of care for ARDS patients. Very recently, we've started doing something called awake prone. I'm going to take a minute on this. It's basically a patient's not intubated. So the patient is awake. They're admitted to the hospital with COVID. They require oxygen at this point. So they're not sick enough to be intubated, but they're not well enough to go home. So they require some amount of oxygen. They need to be in the hospital floors. At this point, we try something called awake proning. And this study was done in New York City. It's a small study with 25 patients. And they put the patients, they check their oxygen level prior to them going prone. So a patient is lying down on the bed, they check their oxygen level. And then they make them lie on their stomach, they prone them, and 1 hour later, they check their oxygen level. So basically, it's a very easy maneuver. All you have to tell the patient, if they're able to do it, is why don't you lie on your stomach? And you see within an hour, the oxygenation of all these patients improved. And this study showed that, even though it's a small study, it showed that this awake proning, where the patient is not intubated, they're on a little bit of oxygen, but they're able to lie on their stomach, it improves the oxygenation and it also decreases the rate of intubation in these patients. So going back to our ARDS COVID patients, so you've optimized the ventilator strategies, you optimize sedation, the patient's still hypoxic, so they're paralyzed, they're still hypoxic, so you prone them and they don't improve. So the next step we go to is ECMO, which is VV ECMO or VA ECMO. There are two types. ECMO is basically extracorporeal membrane oxygenation, where in VV ECMO, you give the lungs rest. So you get the blood out of the patient's body, you use an external oxygenator, which oxygenates the blood, it does the work of the lungs, and the oxygenated blood is returned to the patient's body. And VA ECMO is basically cardiac support. So if your patients have fulminant myocarditis, cardiomyopathy, cardiogenic shock, then they go on to VA ECMO, where it provides support to the heart. So we've had a couple of patients go on VV ECMO, mostly with the severe COVID ARDS. Just to give you an overview of how common ECMO is and what kind of patients need it. This is ELSO, which is an international organization that keeps track of all the ECMO or extracorporeal membrane oxygenation worldwide. So as of September 1, 2020, there are about over 2,000 patients who were confirmed COVID-19. They received ECMO worldwide, okay? Very, very important to note in this, which I think was important for me, was the median age was 48 years old. So the younger COVID patients who eventually developed severe COVID when COVID disease, COVID ARDS, went on ECMO. And it's very important, again, I'm going to link it all back to the goal of our presentation, is the median runtime for ECMO was 330 hours. That's basically 14 days, around 14 days. So these patients were on ECMO for at least 14 days. So they're cannulated, they're hooked up to machines. So we need to focus on rehab in this population. So with that, I'm going to briefly talk about pharmacotherapy. As you see, there are more and more drugs coming out, more clinical trials. So I just wanted to put this diagram out there just so we understand where each of these medications work and the mechanism of action. So as I mentioned before, this is the SARS-CoV-2 virus. It attaches to the ACE2 inhibitor. It enters the cell. Once it enters the cell, it comes out. The viral RNA comes out of the cell. It uncoats. And this is all basic microbiology, where you have proteolysis and translation, assembly, and release or exocytosis. So the drugs we've seen so far are remdesivir, which I'll be talking about in a bit, that inhibits this enzyme, this key mechanism. So they're trying to stop the virus from going beyond this point. And chloroquine and hydroxychloroquine acts in the beginning. It prevents the membrane fusion and endocytosis. And the newer drugs that are coming out, the anti-IL-6, which is tocilizumab and sarilizumab, it binds the IL-6 receptor and prevents the cytokine storm, basically, that's brewing here. I think if you understand the basic viral mechanism, it's easy to understand how the medications work. I know there's a lot of words in this slide, but basically what I'm going to say is all those that are highlighted in red, that is hydroxychloroquine, chloroquine, lopinavir, ritonavir, tocilizumab, convalescent plasma, famotidine, they're all in clinical trials. So based on the Infectious Disease Society guidelines, all those medications have been approved to be used in clinical trials. The most talked about medication, I shouldn't say most talked about because steroids, I'm going to come to steroids, which are actually the most talked about. So up until 2 weeks ago, it was remdesivir, where everybody with severe COVID-19 received remdesivir. And it acts on the viral enzyme, as I had mentioned here in this slide. It inhibits the RNA-dependent RNA polymerase enzyme, and it blocks the viral replication at this point. There's evidence for 5 days use of remdesivir in patients who are not in the ICU, not intubated, not needing ECMO, but need hospitalization. And in the ICU patients with ARDS who are on mechanical ventilation and ARDS, we use remdesivir for 10 days. So now coming to our main topic of discussion, which is the use of steroids. This is based on the recovery trial, which came out about a month ago, where it was indicated for patients with severe COVID-19 that glucocorticoids are more beneficial than no glucocorticoids. So in that study, which came out of England, it showed that dexamethasone 6 milligrams IV or PO for 10 days has benefit in severe COVID patients. However, they said if a patient with COVID had milder illness where they did not need oxygen, they recommended against the use of steroids in that population. I'm going to spend some time on the new data that came out about 10 days ago. New data from JAMA, or Journal of American Medical Association. There were 3 randomized controlled trials and 1 WHO meta-analysis that looked at the steroid use in COVID patients. So first study was hydrocortisone. They used hydrocortisone in critically ill patients with COVID-19. And the hydrocortisone, they looked at 21-day mortality and respiratory support. And So the first study, it was stopped early because the recovery trial with dexamethasone came out. So hence the study was not powered adequately. And so it showed that hydrocortisone didn't reduce the death or persistent respiratory support at 21 days. Another study, which is a multinational study, which is called the CODEX randomized control trial, clinical trial, it was the use of dexamethasone on ventilator-free days in patients with moderate to severe ARDS. And they said, if you give a patient IV dexamethasone in severe COVID ARDS patients, it increased the number of ventilator-free days. That means the patients were extubated earlier than when they were not given dexamethasone. And the third study was hydrocortisone. It showed similar findings, a REMAP study. It showed 7 days fixed dose hydrocortisone led to 93% superiority and versus no hydrocortisone. And WHO meta-analysis, this is a very important paper that came out. It's a meta-analysis of all the randomized controlled trials so far, where steroids were used for COVID-19. And I just want to I want you to pay attention to this slide here. I've marked it as, favor steroids here. So in this meta-analysis, which looked at several clinical trials of, this is the first couple studies are dexamethasone, the last couple studies are hydrocortisone. So regardless of which steroid you use, there was decreased 28-day all-cause mortality. So it favors steroids based on this. The 28-day mortality was decreased when you used steroids in severe ARDS. Again, they subtyped these patients and they said, okay, now let's divide these severe patients into the ones that need ventilation, into the ones that are in shock. Let's also divide them into whether they were requiring oxygen or not requiring oxygen, and even subgroup analysis in severe ARDS ICU patients, there was benefit from steroids. When they looked at adverse effects, they said there was not too much adverse effect with steroid versus no steroids. And so that was another positive thing that came out from this meta-analysis. These are slides from the WHO meta-analysis. Again, it's a very interesting slide to look at. It just, the points that I've mentioned so far, it just kind of puts it in one diagram. So patients with confirmed COVID-19, they can be divided into non-severe, severe, critical. As I mentioned earlier, non-severe, they have no critical severe disease symptoms. Severe ones who are hypoxic, who have, tachypneic, respiratory distress, and critical ones who need ICU, basically. And they looked at no steroids versus steroids, and these are the various steroids that were given. And I want you to pay close attention to the duration. So any of these steroids, regardless of dexamethasone, hydrocortisone, methylprednisone, or prednisone, any of these steroids, the duration was 7 to 10 days. That's a long time for steroids. And this is patients with severe COVID. Basically, they said, we recommend using corticosteroids. And this slide just shows us, what are the serious adverse events they found in those patients who were getting steroids. I wanted to pay attention here to neuromuscular weakness and neuropsychiatric effects, hyperglycemia. So they said, there's not much clinical difference between the ones that received steroids and did not receive steroids. However, the level of evidence was low. That's important to note here. This slide is recommendation 2, where patients with non-severe disease, they suggest no steroids. So if your patient's not severe or critical ARDS, critical COVID-19, there is no indication for steroids. So basic summary from all this is there is solid data now supporting 10 days of any steroid. As I mentioned, it's either prednisone, methylprednisone, hydrocortisone, or decadron. If a patient has severe ARDS, moderate to severe ARDS, that's the recommendation as of now. So I think I've spoken a lot on steroids. The reason is we are going to start seeing more and more steroid use as the number of severe COVID-19 patients increase. And that in turn is going to lead us to our next topic, which I will talk about, the post-ICU syndrome. But that's important to understand how the landscape of COVID-19 management in the ICU is changing. So that will affect your post-ICU care as well. Briefly about other medications that we can use for treatment, neuromuscular blockers or paralytic agents, especially if the patients are severe and there's ventilated dysynchrony. We use those. Bronchodilators are not routinely used because it's not an airways disease. It doesn't cause bronchospasm. So unless absolutely needed, we don't really use bronchodilators in the ICU. And unless you are sure that there is a risk of bacteria, there is a definite bacterial superinfection, we don't really use antibiotics. And the recommendation is early discontinuation of antibiotics in COVID-19 without superimposed bacterial infection. Just to drill down this point, the experience with COVID-19 continues to grow, and the mortality rate is 50 to 97%, especially in ICU population, those requiring mechanical ventilation. In direct comparison with the influenza pandemic, the mortality rate in ICU patients during the influenza pandemic was H1N1 especially was 35 to 46%. So 35 to 46% of the H1N1 flu patients who required mechanical ventilation died. However, with COVID-19, this rate is about 50 to 97% based on which study you look at. So it's much more severe than influenza. Very briefly on cytokine storm. It's uncontrolled inflammation that goes on in the body. There's increased release of interleukin-6 that's thought to be the key player. This is an area of more research. There is some study to say that, this cytokine storm does not exist in COVID-19. So there's back and forth conversations going on regarding this. So there's more to come based on the cytokine storm. So we spoke about ARDS, briefly about cytokine storm. What else can ICU patients with COVID have? They can have venous thromboembolism. So what causes venous thromboembolism? The virtuous triad, as you can see, you've known this for a while now from pathology. It's hypercoagulable state. COVID itself can cause a hypercoagulable state, endothelial injury, damage to the endothelium, and circulatory stasis. All these three, they can cause hypercoagulable states. So this diagram is very interesting, how COVID itself causes VTE. As I mentioned before, the SARS-CoV-2 virus attaches to the ACE2 receptor, and it incites a cytokine storm with increased inflammatory markers. This local and systemic inflammation that leads to the virtuous triad with hypercoagulopathy, low blood flow or stasis states, and damage to the endothelium. So basically, all this can cause DVT. The COVID can cause DVT in itself, DVT and PE. And we have seen a lot of patients coming in with hypercoagulable states just from COVID. So CHEST, or the American College of Chest Physician, has these brief guidelines to help guide us to manage these venous thromboembolism or DVT and PE in COVID patients. Their recommendation is all hospitalized patients should receive prophylaxis. Low molecular weight heparin is preferred. And if you have a patient with confirmed DVT or PE, then full dose anticoagulation is recommended. One line about sepsis. Can COVID cause sepsis? This is from the Global Sepsis Alliance. And basically the answer is yes. So COVID does induce sepsis, indeed cause sepsis in itself. It's most likely due to organ dysfunction and due to the dysregulated host immune response. So this slide is a bit busy, but I want to reiterate that COVID can cause multi-organ dysfunction. There are several case series, especially from Seattle and China, who had seen the initial surge of COVID patients. And despite it being a pneumonia, most of these patients have COVID positive and had lung manifestations. However, if you look at that, based on the studies you look at, 30% had liver injury. In another study, 20% had kidney injury. And about 70% of the patients had severe sepsis and septic shock. In another study from China, about 28 to 30% of patients had severe heart damage. So it's not just the lungs we're talking about. COVID can take over the rest of the body as well. So this is the Surviving Sepsis campaign related to managing sepsis in COVID-19 patients. So what it says is, use crystalloids, balance crystalloids, and fluid conservation strategy. So dry lung is happy lung. Try to keep your lungs as dry as possible. Norepinephrine is the first agent, vasopressor agent of choice. We want to keep the saturation between 92 to 96% and use low tidal volume mechanical ventilation guidelines for ARDS. COVID can affect the brain, and the first picture is very recent, as of last week. There's some hypothesis and also studies from Yale University that shows that COVID, basically the virus enters the brain cells and it chokes off the oxygen to the adjacent cells. So that's a new mechanism how the coronavirus can attack the brain. And the second picture here, it shows risk of ischemic stroke in patients with COVID-19 versus influenza. And you see here, these are the patients who came to the ED or the hospital with COVID-19, and this orange dot is when they developed ischemic stroke. So these patients do have an increased risk of developing ischemic stroke just from COVID. COVID also, there are most other complications include critical illness myopathy and neuropathy that has been reported in literature, and it can also worsen the delirium in ICU patients. This is an early on study from China, about a month from January to February 2020, and they looked at the neurological manifestations. And they saw that the COVID-19 can cause central nervous system symptoms, peripheral nervous system symptoms, as well as muscular symptoms. The cause of death in COVID patients is respiratory failure in 53% of patients, respiratory and cardiac failure in about 33% of patients. And the time of illness to the onset of death is usually about 18 days, 18 and a half days. And if the patients do well, the median time to discharge is about 22 days. So I know there's a lot of information. So before we move on to the second part, I just wanted to make sure everybody understood that, there's a lot that goes on in COVID in the ICU. It's not just the lungs that we're focusing on. The other organ systems are also involved. And that gives us some leeway to go into our my second part of the talk, which is basically post-COVID implications. And I think it's important to understand COVID before we go on to post-COVID. So hence the time taken to explain about COVID. So we'll speak about post-COVID syndrome and one slide on post-COVID interstitial lung disease. So there is a shifting paradigm now. In earlier days, we were like, we were grateful that the patient survived their ICU illness, and we didn't really focus on the post-ICU care. But lately, given all this treatment and the mechanical ventilation guidelines, the drugs that are coming out, the clinical trials, some patients do survive the ICU stay. So what happens next? Surviving critical illness. So where do we go next? So what is post-ICU syndrome? So the patients admitted to the ICU, they seem to have they definitely have cognitive, psychological, and physical signs and symptoms that could last for months to years after their discharge from the ICU. So as you can see here on the right side in this picture, there's increasing elderly population, increasing number of sepsis patients, and given the care that we are able to give using ICU technology and education, the critically ill patients mostly survive. And when they survive, after survival, they develop physical impairments, cognitive impairments, and mental impairments, which affects their long-term prognosis. So in some studies, there was about 80%, that's a high number, of ICU survivors had cognitive impairment. And about 57% had psychiatric illnesses such as anxiety, depression, or PTSD. And about 80%, this is classic for me. It was very surprising because these patients have new physical impairment. So they were not impaired before, or they did not have as much of an impairment, but following the ICU stay, a lot of them had some physical impairment, which could last for months to years. So physical therapy after critical illness, there's a consensus-based framework where this is from one of the societies, which says, we need a structured approach to what will we do with these patients post the hospital stay. So who is at risk for developing PICS? How can we measure their strength? And so there are specific goals, and what do we do with these patients? How do we follow them up? So next week, we're going to hear a lot more on these specific modalities. So I just wanted to give an intro to that. And now looking at the Rehab Society, this article came initially early on in the pandemic in the Journal of Rehab Medicine 2020. It's a commentary on COVID-19 and post-intensive care syndrome, a call for action. So they predicted that this would be coming, a post-intensive care syndrome related to COVID-19. The ICU stay for these patients is very long. It's usually as high as 20 days or more than typical ICU stay in non-COVID related illness. And these patients have higher cognitive, physical, and emotional complications. So extrapolating the data to COVID. So who are the patients who are at risk for PICS? Those who have delirium, increased ICU duration, stay, increased sedation, increased mechanical ventilation, age. If you look at all these, COVID has all these. The COVID patients definitely have most of these risk factors. So they're definitely at higher risk for PICS. The slide shows us about what are the factors that affect or predict PICS. So pre-ICU factors, so your patient's age, do they have other comorbidities? What were they functioning like before they came to the ICU? And how much of a toll did the critical illness take on the patients? Did they develop ICU myopathy or neuropathy? Did they get sedation, steroids, or neuromuscular blockers? Were they delirious? So all those contribute to their post-ICU stay. It's also important to understand the hospital factors, such as how good is your hospital in early rehab? How are they doing with the ABCDF bundle? Do we have enough of our therapists to work with these patients? So that also plays a key role in how these patients recover from the critical illness and the PICS. Again, it's a very busy slide. This basically focuses on muscle weakness in ICU patients. I want to show here the ICU weakness is reported in 60% of the patients who have been on mechanical ventilation for over a week. Even 1 week of mechanical ventilation can cause them to become weaker. 70% of patients with sepsis have weakness, and if multi-organ failure is present in these patients, almost all of them are weak after their hospital stay. The medications we use in the ICU can make them weak. And we don't really pay attention to nutrition. It'll be covered as part of our webinar next week. But key attention to nutrition is important in critical illness, as that also contributes to neuromuscular dysfunction. So ICU acquired weakness. When you look at this diagram here, there are two types. It's ICU acquired polyneuropathy or ICU acquired myopathy, or it could be a combination as a critical illness neuromyopathy. And the cognitive dysfunction, the patients can have delirium, dementia, or depression, or it could be a combination. So it's important to understand this in your post-ICU patients. This slide is from a surgical perspective where, if there's persistent inflammation at the surgical site, if there's poor wound healing, and there's a secondary infection, it worsens your critical illness. There's increased catabolism, mitochondrial dysfunction, that when it's combined with malnutrition, where we don't get help from our nutrition therapist, so the patient has malnutrition, we don't get help from our rehab specialist, so the patient is inactive, so that makes them worse, and the patients go into ICU acquired weakness or PICS. So this is, it's like a circle. It keeps going on and on until we intervene with multimodal approach in these patients. So why is this post-ICU syndrome important? Why do we need to focus on the post-ICU syndrome? So studies have looked at this and showed that about 1/3 of patients who are admitted to the ICU who have PICS, they don't go back to work. And even if they don't go back to work, they don't go back to a job that they had before with their pre-ICU salary. And at least 25% of these patients, they have a loss of independence. They need assistance with their activities of daily living. And this can occur months to years after their ICU stay. So it's not that, patient is admitted to the ICU, they get discharged, they're fine. No, this could go on for years. So that's important to focus on that. I found this very interesting that came out. This is just, a commentary that came out in the Heart and Lung Journal of Acute and Critical Care. It was predicted early on, or somewhere in the middle of the pandemic, that this post-ICU syndrome has the potential to become the next significant public health crisis when patients are discharged from the hospital. So the authors of this paper recommended that planning for this large burden of COVID survivors with post-ICU syndrome should begin immediately. So that's my talk on post-ICU syndrome. So it's coming, more people are surviving because our ICU care is getting better. We are learning more about the disease. We have more medications to treat these patients. So we are hopeful that we'll have more ICU survivors. And so it's up to, what happens to them in their post-ICU scenario. There's more literature coming on this topic, which is post-ICU interstitial lung disease. As I had mentioned before, beyond 2 weeks, the radiological findings in COVID-19 patients show some degree of pulmonary fibrosis. So we're going to start seeing more of these post-COVID fibrosis patients. A small subset of patients was looked earlier in the pandemic, and published in the European Respiratory Journal, where they said at least 47% of patients had impaired diffusing capacity of their lung, and 25% had decreased in their total lung capacity. Again, this is an area of evolution. The more survivors you have from the ICU from COVID, the more of these fibrosis you're going to be seeing in the future. So with that, I think we have to establish screening opportunities. So people are surviving. So how do we screen them? How do we treat them? So how do we find out which patients are at risk for PICS? Which patients need closer follow-up? So I think it does not just focus on the ICU physician. It's a multidisciplinary approach. We need the primary care physician or the general practitioner involved, rehab physician, physical therapist, occupational therapist. They play a major role in the patient's discharge, the patient's cognitive abilities, their independence, their muscle strength. So physical therapists, occupational therapists are very important. Speech therapists or speech-language pathologists, they play a key role as well, especially with nutrition. And psychologists, given all the cognitive dysfunctions like anxiety, depression, post-traumatic stress that happened with ICU stay. Social workers to help with the families and the patients to deal with, how do they go back to normal life after spending so many days in the ICU and rehab. And also the critical care physician. So all of us need to work together to better this patient's care. So the key takeaway for me, so we are in COVID-19 for a long haul. It's going to stay with us for some time. So we have to work on prevention, protecting one another and protecting the healthcare workers. So the more the healthcare system gets overwhelmed, it's going to be hard to protect ourselves and also to take care of patients. So if all the doctors are going to go on quarantine, it's going to be really hard to find qualified professionals to take care of the active sick patients in the hospitals. So that's important. And basically prevention is key. Hand washing with soap and water for at least 20 seconds, social distancing. I mean, we know all this, but the more we hear about it, we just have to reinforce our behaviors. And wearing well-fitting masks is important. And this, I think, might be my last slide where my key takeaway points. So COVID-19 critically ill patients have prolonged ICU stay and prolonged hospital stay. That's just the disease, the nature of the disease and our treatment in order to keep those patients alive. There are several limitations to maximal mobility in patients. These limitations could be due to the disease. What are the premorbid conditions of these patients? Did we use a lot of paralytic and sedative medications and high oxygen requirements? So if a patient's on BiPAP or the patient's on high flow, it's really hard to have them ambulate as much as you would like them to. So every day it's important. I ask myself this on rounds every day. Did the patients achieve maximum mobility or exercise today? So if the answer is no, so it's very high to set your standard high. So it's important to ask the specific questions. Did they achieve maximal mobility and not did the patient move today? Did they achieve maximal mobility or exercise today? If it is no, we have to work around how we can optimize the mobility of these patients. Identifying patients who are at risk for PICS prior to the departure from the ICU. So we know the risk factor for PICS or post-ICU syndrome. So which are these patients who have been in the ICU for long term? Which ones have had delirium? Which ones have been prolonged mechanical ventilated? So it's good for us to capture these patients so they can have close follow-up once they leave the ICU. Early rehab is important. It helps the recovery from COVID-19. And multidisciplinary approach is important. It's not just, preventing the death, keeping them alive until they get out of the ICU. It's also looking at long-term survivorship of these patients. So I would like to close my talk with this one slide. I borrowed it from Twitter. The Dirty Dozen, which is the 12 points to cover prior to COVID disposition. So when you think your patient's ready to leave the hospital or leave the ICU, just making sure were their home medications restarted, stop the new ICU medications, which were started new in the ICU. Do they need to be stopped? Do they have DVTs? Do you need an anticoagulation plan? So the follow-up visits are usually not until a month or even longer. So within that month, if a patient's discharged, they are home. So who follows up with these patients? Who is going to call them and follow up to say, how are you feeling following your ICU stay? Do these patients have an exercise plan? So following up with whom is most important? Is it the primary care doctor? Is this the lung doctor? Is it the neurologist? So that to establish that prior to discharge. Remove all the lines, IV lines from the patient. The next one is written tubes or lines recap. So making sure that we've removed everything prior to them being discharged. Teaching them about what are the common readmission issues, talking to them, educating the patients. And the key is, has PT/OT evaluated the patient? So prior to every single disposition, this question needs to be asked. Has PT/OT evaluated this patient? Can this patient pay for their ongoing care? They spend quite a bit of time in the ICU. Can they pay for the remaining care once they leave the ICU? And expect post-ICU syndrome. It's out there, its recognition is key. So which of these patients are at high risk for post-ICU syndrome, and how can we help them prior to them leaving the ICU? So these are the key points that we keep in mind prior to patient leaving the hospital or the ICU. And that's the end of my presentation. I thank you for your patience for sitting through this whole presentation, and I'm happy to take any questions at this time.
Thank you, Dr. Ramesh. Srividya, are we able to share the screen?
Yes, sir. She has stopped sharing. We can move on to the questions.
Okay, wonderful. Again, thank you, Dr. Ramesh. I appreciate the in-depth discussion and information you've provided. Certainly, there have been a lot of updates compared to the last time that we had this discussion, because I recently listened to that lecture, and there definitely has been a lot of discussion. And also thank you for linking how prolonged ICU stay and treatment that is being given in ICU, although helps with mortality, but it can increase their morbidity, which would then mean the rehab professionals have to play a big role in providing them with a better quality of life. So thank you for linking that. We do have some questions. I don't know if everybody has already figured out where the chat is. As I had mentioned at the beginning of the talk, the chat is on the right-hand side of the video. You can post your questions there. So I'm gonna go ahead and start with some questions that have already been posted. So there's a question that's asking, what is the reason for cognitive impairment in the post-ICU COVID patients?
So I think it's regardless of COVID, I think anybody who stays in the ICU, it's just the disease manifestation, the hyperinflammatory state the patients are in when they get admitted to the ICU. And the medications we use to treat them, steroids themselves can cause some neurocognitive issues. Sedation, definitely, it changes the day-night orientation of patients, and paralytics. They also affect the mobility. So it's also, I think it's important that we recognize delirium in these patients. That's the most common. They're not in their home settings. They're septic or they're hypoxic. That itself increases the risk of delirium. And I think the other cognitive impairment is anxiety. So if a patient has that severe illness that they're not able to breathe, not being able to breathe is a big deal. You get really anxious when you're not able to breathe as you were before. So that's why it's important to recognize anxiety and treat it appropriately in these patients. And depression, like now with COVID, there is not as liberal visitation guidelines as they used to be. So if a patient has COVID in our health system, we are not allowing family members to visit them. That's for, I think, the overall safety of everybody, the community safety of the healthcare workers, safety of the family member. But I think looking at it from the patient's perspective, it's there by themselves in their ICU room. They're very ill, and they have no family to support them. So I think those are the main reasons why these patients end up having some cognitive impairments long term.
Got it. So in essence, it's not just cognitive, but also cognitive and mood issues as well. And cognitive, seems like a lot of reasons. Sedation, as you had said, they're much more severely ill compared to, I think you had compared with the flu patients, how they're much more severe compared to them. And which means that they're probably they're probably under sedatives for a much longer period of time, and also hypoxia plays a big role. I think you had mentioned that. So hypoperfusion.
I think it's important, like new literature. I think by the time, in the next couple months, we should have more where there's direct cytopathic effects. The virus itself enters the brain, it deprives the other cells of oxygen, and that itself causes neurological and behavioral changes. So there's that space. It's a space to watch out for. We're going to see more literature on that.
So multifactorial, basically. There are a lot of reasons that could put them at risk. Yeah. So other question that we have is, can I know how far a negative pressure ventilation helps?
So, all our patients are on negative pressure if they have COVID, especially if they're getting aerosolizing procedures like high flow or intermittent non-invasive ventilation or nebulizer medications. I think there's still, the jury's out there. Is it droplet? Is it aerosol? We don't know. But once a patient comes to the ICU, they're very ill. And so their burden, the disease burden is much higher than somebody, maybe you see in a grocery store and they have COVID, but they're fine. They don't have that disease severity. But once they come to the ICU, I think they are very ill and they definitely would need to be on negative pressure ventilation. Again, the jury's out there. We can't say anything for certain, but we treat them, when they come to the ICU, we treat them like it's an aerosol transmission.
Got it. I hope that answers the question for that person. So I have a few questions that I'm going to go ahead and ask, and I'll give some time for the listeners to think about questions and post the questions, because we have noticed that there is a delay, of maybe 15 to 30 seconds or something like that between the platform that we are on and the YouTube channel. So we'll let them do that. So a couple of the questions that I had was, you may have mentioned this, but what I wanted to know is, what is the percentage of patients that would fall under the category of severe, like severe disease?
I think overall, right, like as I mentioned in one of the slides, 80% have minimal symptoms or they're asymptomatic. So in the remaining 20%, a third of them will come to the ICU with critical illness. And in that small population of, a third of those patients, about 10% need mechanical ventilation. So it all depends on your total number. If you have only 100 patients, that's very less. But if your total is going to keep going on in millions, then your ICU population is definitely going to be higher.
Absolutely. And how does that compare against, again, I'm using the same analogy, influenza?
I mean, I think initially, it's an evolving disease, right? So in the beginning of the pandemic, we were told that it's similar to the flu because it's a virus just like the flu. But I think as we learn more about the direct cytopathic effects of this virus, how it can affect the brain, how it can affect the rest of the body, I think it's definitely different. One of the studies that I showed compared the risk of stroke between flu patients, H1N1 flu patients, and stroke in COVID patients, and the stroke risk was higher in COVID-19 patients. So we're going to see more of that in the future, but I think it's definitely different from flu. It's much more severe, and it can cause multi-organ dysfunction. And the other thing to understand is with flu, we've had, in the past several years, there have been multiple strains of flu. We've had vaccines. People have some degree of immunity to the flu. Even if they're not 100% immune, they have some degree of exposure or vaccine, some immunity. But With this disease, it's new.
Yeah,
We
no
have
immunity.
zero innate immunity, and we have no vaccine. We've not been vaccinated for any kind of strain. So that makes a big difference with
Absolutely.
COVID-19.
Absolutely. And there have been some, I don't know if it's discussion or if you can call those facts, but just, I guess, based on observations, it's not as severe as it used to be. Based on your observation, of course, I don't know what the data is out there, but based on your observation, is that the case? Or you think that the severity is still as much as it was before, and the incidence of severe cases are pretty much the same as it was before?
And I think it's still there. Like, I work in the ICU, so I see the sickest of sick patients. So in the ICU, the population is still very sick. Once they hit the ICU, they're extremely sick. But I think the difference is, early on, a lot of cases, it was like a bolus, like a lot of cases came at one point in time, or a very limited point of time. Within a week, within a month, we had so many cases. So paying attention to everyone was, we need to protect ourselves. We need the PPE. We need to make sure we treat the patients appropriately. And we did not have literature on anything like, did steroids work? Did they not work? What is remdesivir? People did not even know about it. What is plasma? So I think that was the thing early on, a bolus with a limited time with little knowledge on the disease. So that could have played a role in the increased mortality in the early on in the pandemic. But as we progress, as we go deeper into the pandemic, we have more treatments. It's a little bit more controlled. The hospital systems are also, they have their own strategies. Initially, they did not have much time to develop like a contingency or crisis strategy mode at that time. But as we go on into this, I think we're getting more organized. The literature is becoming more peer reviewed, because in the beginning, it was basically like social media, like, I saw this patient with COVID, I gave this, and what are you doing? But now we are seeing like journals coming out with good quality evidence. So I think that's the big difference.
Absolutely. So I had a question regarding prone positioning, particularly prone with awake, because when they're sedated and prone, they're fine. Are you experiencing difficulty? Because we've had a few patients and they were complaining of not being able to be on prone positioning because they just couldn't tolerate it. Is that something that you see? Do you have any strategies that you use?
I think, this is also evolving. Nobody spoke about awake proning until well into this pandemic. There are ongoing multi-center trials with awake proning. It's more to do with, the patient's body habitus, the patient's pre-morbid conditions. Were they, oxygen-dependent COPD to begin with? Did they have CHF? So the patient condition plays a role. And the third one is the disease severity. Like, we've had a couple of patients who did great with proning, and some were able to tolerate like a high flow nasal cannula and be awake prone, so we could avoid intubation. But some of them could not, even when like 2 days of awake prone on high flow, they were just decompensating. They needed intubation anyways. So it's all patient dependent, disease dependent. And the study that I showed you was just 1 hour of prone positioning improved your oxygenation. So as much as we can, we should try to advocate for this. If a patient can follow commands, if they are cooperating with you, their body habitus allows them to be prone, I think that would be the initial strategy to avoid intubation and all the complications that come with mechanical ventilation, sedation. So that we try that first.
Got it. There's another question. I'll just ask the way it's written. Coagulation nature of blood after ICU stay, generally. I think they're just trying to ask, because you had talked about VTE. So after ICU stay, after ICU stay, do they need, I guess they're asking, let's say they don't have a VTA, after ICU stay, do they still need to be on anticoagulation for prophylactic purposes?
After leave the ICU stay. So this is again evolving. So from what we have, the consensus guidelines put out by the American College of Chest Physicians, they recommend prophylaxis for inpatients with COVID. There is no data as to outpatients who have recovered from COVID, who did not have a documented DVT or PE. There's no evidence for them to be on anticoagulation so far. If you had COVID and if the patient had COVID and they had a DVT or PE, then there's indication to continue anticoagulation, and that the jury is out there as to do you give them 3 months of anticoagulant medication or 6 months. More physicians are leaning towards longer duration of anticoagulation, more towards the 6-month mark. That's if you have a confirmed DVT or PE. But if you did not have one, they recommend prophylaxis while you're in the hospital, but no prophylaxis is indicated once they get discharged.
Got it. I've thought about this actually. I've seen orthopedicians after either a knee replacement, hip replacement, or sometimes even after some fixation surgeries. They tend to do, I'm sure you've noticed as well, sometimes they do high dose aspirin twice a day or even small dose aspirin twice a day for DVT prophylaxis. And they actually ask them to continue for, I think, a month or two, even as an outpatient. So I always wondered, with some of these population with stroke, would they, especially because the first 3 months, they're still at high risk for developing DVT just because they're being discharged from the hospital, so they're not be on it. But I think definitely that's an area that needs to be explored.
Exactly, yeah. Mm-hmm. I think if you look at the orthopedic population, they're very different from the ICU population. They are healthy, they are walking around, they have no comorbid condition. It's usually an elective surgery. They get admitted, they get surgery. Day one, they start rehab, have PT at bedside, and they don't have anything else going on other than that particular joint that's been replaced. Yeah. So there's no systemic inflammation and other inflammatory markers like you would see in ICU patients with ARDS or septic shock who recovered prolonged ICU stay. So I think when we look at that data, we just want to make sure we're looking at the same patient population. I think the ambulatory orthopedic patients are much different than ICU patients. So ICU patients are definitely, much sicker, more procoagulant than their joint replacement population.
I agreed. Yeah, that's exactly what I was thinking too, because these patients are at a much higher risk, yet the lower risk population are being put on anticoagulation for a month or so, even as an outpatient. So that's why I was thinking perhaps this might be an area that needs to be explored a little bit more. So with that being said,
it's funny, like I just get reminded on this because we had a rehab unit where I was training, and then whenever we had a rapid response, we always think it's going to be PE. It will be like a joint replacement or something, and we'll hear a rapid response in this rehab unit. That would be our first thought.
First thing, yeah.
First thought. So, I mean, even though they're on aspirin, they do have a risk of developing DVT.
Yeah. So we have a couple of questions. I'll do one at a time. It's from the same person. They're asking, well, first of all, they said very useful session and they learned a lot of new things.
Thank you.
The questions are basically, number one, whether steroids are useful in early COVID phase with mild symptoms without hypoxia, but CT chest showing mild GGO. I'm not sure what they meant by GGO.
Okay, that's the ground glass opacities, the CT abnormalities on the early on stage. So I think the simple answer is going to be no, based on the evidence we have. So the thought behind this, right, based on the recovery trial and also the 3 randomized control trials for steroids in COVID and also the WHO meta-analysis that came out, they're recommending against using steroids in patients with mild symptoms without hypoxia. So the thought process is early on in the disease, if the disease is mild and you're healthy, your body mounts an immune response against COVID. So your body is trying to fight it. So if your disease is mild and you give steroids on top of it, you're going to blunt your own immune response and you're going to make your disease worse. So that's the thought process, that's why they usually don't recommend giving steroids in mild cases. However, if your body's fought enough, your body's immune system gets overwhelmed, then they move on from mild to severe disease or moderate disease. And at that point, your body needs help. So we give steroids. But initially, the thought process is to just let your body do its thing, get over the illness if it can. And so we don't want to blunt the immune response at that point. And I think the CT finding, if it's mild ground glass opacities, that's any viral infection can cause that. I would not be, that would not be my indication to start steroids. Just because, I mean, look at the patient. If they're not needing oxygen, you don't think they need to be admitted to the hospital. They are maintaining oxygen saturations over 92%. And you have this mild ground glass opacities. I would not focus just on these opacities. It would be more the clinical picture rather than the CT findings.
CT finding, understood. So another question, by the same person, post-COVID ILD management. I don't know if they're asking, will you use steroids in post-COVID ILD management or general post-COVID ILD management, but you can answer both.
I think it's, again, up in the air. Post-COVID ILD management, we will definitely see more in the next coming years, because the ILD for post-COVID is usually a fibrotic type from what we've seen so far. By 14 days, beyond 14 days is usually fibrotic. And if you look at the fibrosing lung diseases that we have, like IPF or, any other fibrosing ILDs, steroids usually don't work for them. They need immune modulating medications. But we don't have that literature for COVID pulmonary fibrosis yet. But I'm sure, as we have more survivors, we are going to see more and more on that.
Got it. So this will be the last question. So further questions, what we'll do is we will note it down and send you an email or text it to you. You can send us a response and we will let them know about your answers. So whoever has further questions, what you can do is post your questions with your contact information, email or WhatsApp number, and we will get the answers from Dr. Ramesh and we will let you know. So the last question is, have you come across, this is an interesting question, have you come across a COVID patient with hemophilia?
Me personally, no. I have not come across a patient with hemophilia, and I have not looked up any case reports.
Okay, I think the implication is basically, hemophilia, are they at high risk? Are they still at high risk for hypercoagulability? I think that's what they're trying to get at.
It's possible. You never know. Like I said before, prevention is better than cure. So just because you don't have any comorbid conditions, we are not recommending that you go out without a mask, have close contact with people, So I think prevention is better than cure, regardless of hemophilia or any other disease. It's always try to prevent. If you get COVID, then we can get the treatments based on the disease severity. But I guess at this point, we're just focusing on prevention. If you think you're high risk, if you have underlying premorbid conditions, that's another reason why you have to be much safer than the general population.
Right. Now, I think I have the same question too, since that person asked now. From a VTE standpoint, from a venous thromboembolism, somebody with hemophilia, will they still be at higher risk? Will they still be at the same risk for developing VTE if they get COVID as somebody who didn't have hemophilia?
And it's interesting you asked this, because last week I had a similar patient where similar kind of situation, but we don't know. It's all up in the air. It causes.
I would imagine it's very difficult to know as well, especially considering that there are so many number of hemophilia patients. Out of them, how many are contracting, and then so it's going to be difficult to study as well.
Yeah, so it's basically like COVID itself can cause hypercoagulable state, but if you have an underlying hypercoagulable state, does that make you even more prone to getting DVTs and PE? We don't know. We've seen patients with no hypercoagulable state. We have have no previous PE or DVT, no hemophilia, nothing else going on. They come with DVTs and PEs. So it's a gray area. I'm interested to see what happens, in that space.
Agreed. All right. Again, thank you very much, Dr. Ramesh. Always a pleasure.
Thank you.
And as I said, if we have any further questions, we'll let you know. And again, truly appreciate your time. And thank you.
Yeah, thank you for
And-
having me, and it was a great experience. I'm very interested in this topic. It's evolving, so there's more for me to learn, for everybody to learn. So it kind of keeps you on your toes.
Absolutely. And to all the listeners, thank you for participating in this first of a 4-day webinar series. As I said at the beginning of the talk, we have various speakers, and the next speaker will be on the 16th. I believe that would be next Wednesday, same time. And you can see the name of the speakers. And I think you have 2 more days after that. So log in or subscribe to the YouTube channel, and you should be able to, when you get to the homepage, you should be able to see the live stream when you go to the homepage on the day, on the time of the presentation. And again, if you have any further questions, you can contact the email address and the phone number that's listed on the invitation. Again, thank you all for participating. Thank you, Dr. Ramesh.